Okay, I suppose we can get started again with our next speaker. So we have Meredith Beaton. She is an assistant professor and the APP clinical director in the Division of Hematology here at the University of Colorado. After working for several years as a middle school teacher and researcher, she returned to nursing and became an NP through the Yale School of Nursing in 2016. Meredith serves on a variety of committees within UCH and the University of Colorado. She also helps plan this blood cancer boot camp. Also, Meredith is the medical director of the inpatient unit for the Division of Hematology, the only APP medical director in our institution. Meredith has presented at national conferences and been published in JADPRO regarding her blood cancer expertise. She also lectures at the CU College of Nursing. When not working, she enjoys adventures with her 4 daughters. So please welcome Meredith Beaton for her talk on acute myeloid leukemia.
Okay. Well, thank you everyone for being here. Thank you for having me. I just want you to know you can take the middle school teacher and put her into the healthcare workforce, but you cannot take the middle school teacher away from me as a person. So this lecture is going to be very much like how I would, teach in a classroom. So I apologize. I'm going to expect some audience participation. Great. No pressure, anyone. Okay. Here's what we're going to talk about today. The initial management of a newly diagnosed AML patient, some of our common oncologic emergencies, which says that are associated with AML, but really you can think about them with any hematologic malignancy, and identifying patients eligible for germline mutation testing. And this is a topic near and dear to my heart, so we'll focus a little bit of time on that at the end. I have no relevant financial disclosures. Great. Okay. Our patient case. Based on a real life patient that we have, 35-year-old female, no significant past medical history, presents with approximately 2 weeks of shortness of breath. This is always how an acute leukemic rolls into the hospital. Like, oh, I have this very benign symptom. I don't think it's a big deal. Just tell me that I have the flu, please, right? And let me move on with my life. It's been progressively worsening for her though. And so she came into the ED, and on arrival, her SpO2 sat was 66%. A smidge concerning, definitely, but she's young and otherwise healthy, so no wonder she was compensating really well out in the real world. We do a little CBC because I'm sure the ED attending is like, well, that seems odd. This could be pneumonia, or it could just be that she has iron deficiency anemia, because that's an often assumed problem with younger ladies, right? Find out that her white count is 160,000 with 56% blasts. Not good. Right? Immediately, we know that this young woman has acute leukemia, right? Yeah, I saw some mouths moving. Okay, thanks, guys. Thank you for your participation. Hemoglobin, 12.7%. Oh, sorry, 12.7. Platelets, 17. Oh, this picture is just getting more and more, I don't know, progressively worse for her. Cardiac workup, though, is negative. That's great. RVP, also negative. I can't say that I'm terribly surprised at this point, right? So for our patient, we start to say to ourselves, oh gosh, what do we need to do immediately, right? Because this ED provider has now had a mild panic attack, right? And they have immediately paged us. Yeah, us. Exactly. Thank you. Okay. And I say to myself, oh gosh, yes, she has acute leukemia, but what am I actually more worried about now with this lady? I mean, okay, yeah, we can treat that. Right? I say to myself, oh, shoot, I wonder if actually she's having this oncologic emergency. So the first thing that I worry about with her is that her white count was over 100,000, and she is showing signs and symptoms of this phenomenon called leukostasis, right? And so this hyperleukocytosis, this super elevated white blood cell count, is something that we worry about in a patient with acute leukemia, in particular with our AML patients. It can happen in any type of leukemia, but in particular, we think about it with our AML patients. And the reason that I say that is because I always think about those blast myeloid cells as really gumming up the pipes of your vasculature. They're big, they're awkward, and they get stuck in places and they essentially cause clots. But clots not made up of platelets and sort of all of the clotting factors, but rather clots made up of white blood cells chunking around in there. And you can imagine that that makes for a very unpleasant experience for patients, right? And as you start to have these clots that develop in different parts of your system, you will start to see the side effects of that clotting. For this patient, right, these clots are developing in her, or this leukostasis picture is happening in her lungs, right? And that is what is actually causing her decreased oxygenation. And so we want to think about what potential end organ dysfunction would we be seeing in a patient who has a white blood cell count that high, so that we can decide, is this patient showing sort of this emergency situation where we need to act rapidly in order to get that white blood cell count down, or do we have a little bit of time to buy for ourselves? Some of those other signs of leukostasis could include some CNS alterations. You can imagine if we were gumming up the brain, right, what that might manifest itself as. Respiratory distress, as we talked about. In about 80% of patients, you're going to see a fever of some kind, but also you might see other end organ dysfunction, like a myocardial infarction. You might see renal dysfunction, right? You might see priapism in a male. You might see some bowel infarction, right? This can manifest itself anywhere. All right. I will say that under the treatment category, our mainstay is to go straight to hydroxyurea. I would say traditionally, there's a lot of talk around leukapheresis. This is always what the MICU wants to know right away. Can we leukapheresis patient? And that is a lovely idea in theory. And it works really, really well when it works. The problem is that if you can imagine, right, we have to page the apheresis team. They have to come to the hospital. They have to put lines into this patient. We have to get the machine set up. Then we have, and you can see, right, so on and so forth. This is a process that can take up to 6 to 8 hours. Does this young woman have 6 to 8 hours for us to start to treat this? Probably not, right? But I can give her a dose of hydroxyurea right off the bat. And I can start to drive that white count down immediately. And so we try to do a combination of this. I will say that the ELN guidelines do tell us that we should have prompt initiation of chemotherapy in these situations. The tricky part, again, is that what would I be treating? I can make a lot of assumptions that this woman probably has AML. However, if she does not, and I treat her with the wrong chemotherapy, I've made a pretty grave error in my management of this patient, right? So it tends to be that we'll treat upfront with hydroxyurea. We'll start leukapheresis if we have to, if someone's showing signs and symptoms of leukostasis, as our patient is, and then we'll get a diagnosis and start to treat their underlying disease. Okay. Whew, one crisis averted. Now we can get back to treating her AML, right? Ah, sugar. I forgot she had a blood cancer. These blood cancer patients, they really like to throw you for a loop all the time. You think you fix one thing and they crop up with something else. And in our case, our patient who was treated with her hydroxyurea, we leukapheresed her for leukoreduction. Look at this. Her white count is coming down. It's now 111,000. Hemoglobin's 8.3. Platelets are 36. But now her dimer went from 9,500 to 84,000. And her fibrinogen went from 257 down to 135, and her INR went from 1.4 up to 2.3. That is a problem. What problem is this as we are thinking about our hematologic malignancy patient? Well, I hear some whisperings. I hear them. Okay, hopefully you are saying to yourself, disseminated intravascular coagulation. Okay, so DIC, not unique to the heme malignancy world, but it does tend to crop up for us a lot, right? In general, you think about DIC as being, okay, shoot, there is this over clotting that starts to happen in the system, right? We have this dysregulation caused by some underlying process, again, in our patient. That happens to be leukemia, right? And so her platelets and all of her clotting factors start to clump together because they don't know what they're doing anymore because our hematologic system is being affected. They make all of these clots everywhere. And then, wait, is there an infinite supply of those? No, there's not. So I use them all up, making these little microclots in all the vasculature, and then I run out of them and I start to bleed out everywhere. This is a real problem, right? Again, oh, shoot, these heme malignancy patients, very tricky. So I have this bleeding and clotting. And then as I start to bleed, I can't make any more clots. And so then do you see how this is a perpetual cycle, right? Until I fix the underlying problem. And again, we talked about it's very tricky to start treating leukemia until I know exactly what's going on. And another shocker for us, I know, chemo doesn't work immediately, right? As we've heard, right, from a variety of our other speakers today, and as you'll continue to hear, we've got to give it like a little time, right? It's not a silver bullet. And so while we're trying to fix these problems and treat her underlying disease, we got to band-aid this DIC picture. I will just note DIC can show up in a lot of other diseases, right? It can show up in severe infection, it can show up in trauma, but for us, we're worried about our heme malignancy patients. How do I fix DIC? I'm going to band-aid it. That's all. I'm just going to give her blood products, pour those into her until she stops, hopefully bleeding and clotting, because I will have done my job fixing her underlying leukemia. I am just buying myself time by giving her clotting factors and replacing her platelets. That is it. I'm not fixing anything by transfusing her, right? So it's a little bit tricky. I still have to do my job in the other realms, right? In order to manage her DIC. How do I fix this? Basics. I give platelets if she has low platelets. I give FFP if she has a high INR. I give cryoprecipitate if she has a low fibrinogen, and I'm going to give her some red blood cells if she started to bleed and her hemoglobin gets too low, right? Okay, so now we can really get back to treating her AML. I hope that most of us are familiar with the fact that AML is one of the most common adult leukemias, the most common adult leukemia, with just over about 20,000 cases anticipated in 2024. It tends to affect older patients. Greater than 60% of our cases occur in patients who are 65 or older, but it can present at any age. And I will just highlight this for one moment and say, one of the big reasons that we in the field traditionally have always thought about this is because we say, yes, this makes perfect sense. You, throughout the course of your lifetime, you walk around, you eat Cheetos, you go to concerts, you do all kinds of things, and you expose your body and all your bone marrow and all your genes to all kinds of insults, right? And then you get some mutations over time, right? Those are known as somatic mutations. And those eventually lead to some not so great mutation that gives rise to AML, right? That has been the traditional thought process of how, in particular, older people get AML, right? And then if you are younger, terrible luck. So sorry, right? Okay, this will become important later on when we start to talk about germline testing. So I do just want to highlight that. Our treatments, I will also say, have until the last, let's say 10 years-ish, plus minus, we have relied very, very heavily on traditional chemotherapy. And this is also really important for not only my talk, but for Allison's talk later on in the day, because this field has tended to not change for a very long time. Part of the reason for that is because AML is this very heterogeneous disease, right? There are a lot of different types of mutations that can give rise to AML. And that makes it really tricky to treat. Any of you who work in AML or targeted therapies, you know this, right? Not everybody has the same types of mutations that give rise to AML. And that's what makes it so, so complicated. All right. But how do we diagnose this for our patient? Usually our patients are going to present with manifestations of bone marrow failure. So they're going to have some kinds of symptoms like fatigue, fever, infection, bleeding, right? Something that tells us that those counts are likely low. AML sometimes presents with that hyperleukocytosis picture that I mentioned. AML also will sometimes present with these sort of extramedullary sites, whether that is myeloid sarcoma or that is something more like leukemia cutis, right? It can affect a specific organ, but not as often, but it can happen. And then the other thing that we think of is, you know, in order to actually understand what this patient's AML is, the gold standard is we need a bone marrow biopsy. We got to get into that bone marrow, pull out some of those cells, look at them under a microscope and with all of our other different types of analysis and figure out exactly what is going on, right? So we know that we're going to get both sort of bone sample and hopefully blood sample from inside that bone marrow and send it off for all of the traditional tests that or the now traditional tests, I should say, that we think about, right? So we're going to do FISH, we're going to do molecular, right? All of these different flow cytometry testing that we can do. At a minimum, we're also going to check for specific mutations that could give rise to AML. Again, European Leukemia Net colleagues tell us that we need to think about FLT3, right? Both the ITD and FLT3 TKD, TP53, NPM1, RUNX1, ASXL1, and the CEBPA mutations, as well as IDH1 and IDH2, because we do have targeted therapies for those as well. All right. And then we think about treatment. You'll notice this is my lovely timeline of treatment in AML. There's that little box. 20 years, no advancements, right? It's a funky thing to try to treat this very dynamic disease, right? So cytarabine, daunorubicin has been around since the 70s. It is still our mainstay of treatment in the 7+3 regimen. And then we started to get a couple of targeted therapies, right? Gemtuzumab, idarubicin, midostaurin, and then we hit the early or late 2010s, right? And suddenly we started getting all kinds of targeted therapies. I am not going to spend this talk talking about targeted therapies. Allison is going to take that over this afternoon because there has been so many that have been developed. I will point out that what didn't even make it onto this slide, although it was published just in 2020, is both our quizartinib, which was approved for our FLT3 ITD mutations and upfront AML therapy. That was just approved in 2023, as well as our olutasidenib. I'm not saying that right, but Olu, as I know it, for our relapse refractory IDH1 targets. So again, more and more therapies coming out all the time for these patients, again, because of that heterogeneous makeup of the AML patient population. All right, so before 2017, when we started to have these targeted therapies available to us, fit young and fit elderly patients, intensive chemo, that's what we bought you. 6 weeks in the hospital, say goodbye to your family, have all of these awesome side effects, right? You're going to lose your hair. You're going to be horribly nauseous. You're probably going to get infected of some kind because your counts will be so low, increased risk of bleeding, potential cardiotoxicity. I mean, the list goes on, right? This is no joke chemotherapy, and it is rough for patients to go through, right? Unfit or older patients, they can't go through all of that, right? Alex talked quite a bit about comorbid conditions. We can't put somebody who has a severe cardiac history through all of that, right? So instead we go to our hypomethylating agents, azacitidine or decitabine, or low-dose cytarabine. And then if you had relapse or refractory disease, we did not have many options for you. When I talk over at the nursing school, I'll say like, oh yeah, so we would give you 7+3, we check your day 14 marrow. If it hadn't quite worked, then we'd give you this other regimen called 5+2. Same chemos, just more of them. And they'd be like, why would you do that? And you say, well, because that's all we can do, right? Like that was what we knew to do. And so now we're having more options, and that's really, really great. I will say that, the side effects that come along with this, in particular, the cytopenias, like profound cytopenias for a very long period of time after treatment, puts these patients at risk for all kinds of complications. The mortality rates that are associated with induction chemotherapy are about 5% in our clinical trials, but if you look at real world case studies, it's about 20%. So that's, again, no joke, right, when we admit a patient to the hospital for induction. However, in a new era, with all of our targeted therapies, we have a lot available to us, right? We can offer patients all kinds of targeted therapies that not only are we going to perhaps throw you into a tailspin, but we at least can target your very specific mutations, or Or, as we all know, we can also offer what I fondly refer to as chemo light, which we will talk about in a little bit, but much less intensive chemotherapy in order to get our patients into a remission. So we want to think about what is our patient's risk of relapse as we start to treat their leukemia, right? That will help us understand which path do we go down, what do we target, and what's their ultimate end goal, right? And so we have these lovely guidelines. Unlike in some of our other heme malignancies, like as Alex was talking about earlier, right? We can say, oh, you have this specific sort of grade of, you can have a high grade myeloma or lymphoma or MDS, right? In AML, there is no high grade, low grade. There is just, you either have AML or you do not. What we need to know is what is your likelihood of relapse after we treat you, right? That is what sort of guides how aggressive we will be with your therapy. And so we think about different risk categorizations: favorable, intermediate, and adverse. If you have intermediate or adverse, we're not going to beat around the bush. We're still going to treat you as aggressively as humanly possible. Typically, that will send you to a bone marrow transplant. If you have a favorable risk mutation, then we can think about just treating you with chemotherapy in order to try, and likely a targeted therapy, but just chemotherapy in order to get you into remission, and then some consolidation later on. And then look at this. This is how treating AML looks these days. It's pretty exciting, right? If I have core binding factor mutation, I can get intensive chemotherapy plus go. If I have a FLT3, I can get intensive chemotherapy plus midostaurin. If I have an IDH, I can get AZA plus ivosidenib, right? This is very specific based on my personal disease, right? Talk about personalized medicine. This is it, right? And as we start to come out with more and more therapies, we will have more and more to offer patients in order to try to keep their disease under control and in that remission state. So for our patient, she fell into our intermediate or adverse risk. So she was going to go to transplant. We could have been in the favorable risk category where we want to think about consolidation. If we had been in the unfit category, started our patient on azacitidine or decitabine. We'll have a slide later on about what that will look like, especially in the newer age where we have venetoclax to add to that mix. But for our young, fit, healthy patient, right, she's going to go induction chemotherapy straight to stem cell transplant. So we do that. We are able to add this quizartinib, which is a newer medication, our FLT3 ITD inhibitor, to her treatment plan, as is indicated in the guidelines. On day +8, though, of her stem cell transplant, as she is cruising along, she gets this fever of 38.1. Her white count is 0.9 and her ANC is 0.2. Now what's happening? I told you, these heme malignancy patients, they don't stop throwing wrenches at you. They're like, how can I keep you on your toes? Especially usually at 2 a.m. This is our tried and true oncologic emergency. We all love to talk about it, neutropenic fever. So even though she is not necessarily having any other vital sign changes, because our patient is profoundly neutropenic, and we know that she will be for several more days, potentially weeks, and she has this fever of 38.1, which falls into this range of 38 to 38.2, sustained over 1 hour, or a single temperature of 38.3 or higher, we will immediately treat her as though she is septic. If she had other vital sign changes, we would throw her into the severe sepsis category. Our patients do regularly, I would say, progress to septic shock very, very quickly. And so when we think about how we want to treat this, again, she falls into this neutropenic fever category. Yes, we're going to get vital signs. Yes, we're going to get labs. Yes, we're going to get some diagnostic testing. The most important thing that we need to do is draw those blood cultures as expeditiously as possible so that we can hang her antibiotics within 1 hour. This is not only true within our IDSA guidelines, but also within our Surviving Sepsis campaign guidelines. Those antibiotics getting hung within an hour are life-saving for our patient, to the point that every hour delay beyond the first 60 minutes increases her mortality by about 7.6%. So again, no joke treating these heme malignancy patients, right? When we think about how we want to treat her, our first go-to antibiotic of choice is going to be our beta-lactams, typically cefepime. However, if you want some anti-pseudomonal coverage, you can go to Zosyn. If you need some carbapenems because you need more gram-negative coverage, then we could go to a meropenem. If you have concerns for a gram-positive infection, we could think about vancomycin. And in rare cases, we might need to think about an aminoglycoside. So our patient, thrown onto some cefepime as part of her neutropenic fever interventions. Her infectious workup was mostly negative, and we treated her empirically until she had count recovery, which was great. If we had a patient instead who was unfit or elderly with no targetable mutations, then we would want to think about our newer therapies available, which are venetoclax plus a hypomethylating agent, decitabine, azacitidine, kind of depends on your institution, which one you're going to go with. And then we could also consider venetoclax plus LDAC. If our patient is not going to be going towards a transplant, then they will stay on maintenance therapy. Again, very similar to what I believe Alex was talking about, where over time, what that maintenance looks like is going to be a little bit individualized, right? If I can stay in a remission and get my Ven-Aza and maybe come off of Aza for a little bit, go back on, if I can broaden out how long my times are between my azacitidine infusions, right? All of those are up to the discretion of the oncologist, but we do have options in terms of that maintenance therapy. There's also a new oral Aza option, which is really fascinating for a lot of patients and really appealing because, as you can imagine, if I get to cycle, I don't know, 52, that means I'm potentially 5 years into my treatment. Do I want to keep coming in all the time for my Aza infusion? No, I do not, right? So again, lots of options and lots of advancements in the field that have allowed us to meet that quality of life piece for our patients. So I ask this question, but why? Why did our 36-year-old otherwise healthy patient, not 65, hasn't necessarily exposed herself to a lifetime of terrible insults, right? Doesn't, have anything that she, doesn't work in a lab down in New Mexico, right? Exposing herself to all kinds of radiation, perhaps, right? Why would she get AML? Terrible luck? Could be. But we started to ask ourselves in the field, that seems so weird, right? Like you can't have this many people with terrible luck all the time. That just doesn't make sense, right? And then for those of you who have been around long enough, we used to tell people, well, you had an uncle who also had AML. I mean, that is just terrible, but also terrible luck. Like your family must just, you must live somewhere kind of funky. There must be something in the water or whatever, right? We came up with all these reasons that we would sort of explain because we didn't understand at the time until we started testing people for what we now know of as germline mutations, right? That in fact, there are more precursors to AML that are in your DNA from birth, right? Passed down from your parents than what we understood before. For several patients, it is not just terrible luck. It's in their DNA. So much so that we actually think that if we were to test all patients, that their rates would be about as high as they are in ovarian cancer for germline predisposition to AML, which is pretty high. If you think about all of the testing that we do in our solid tumor patients, right? If you have a family member with breast cancer, right, they get tested for germline mutations. Their family members get tested for germline mutations. We hear about BRCA1, BRCA2 all the time in the media, right? If we're having rates as high in the heme malignancy world, we should have more robust systems, right, for not only offering testing for patients, but also offering counseling and testing for their family members. So this is something that's near and dear to my heart. We recently established our own germline testing program here at CU. But what we're recognizing is that as more institutions are adopting germline testing. About 4 to 13% of our AML and or MDS patients are due to an inherited predisposition to that disease. Pathogenic germline variants in our MDS patients are across all age spans. And so what gets very tricky about this, if you start to think about it, is let's say that you have a person who has a DDX41 mutation and they do not develop AML until they're in their 70s, which is very typical for a DDX41 mutation. Remember, this is a heterogeneous disease. So these germline mutations can give rise to AML at any point across the lifespan. That 70-year-old patient has potentially gone on to have children. And they've had children who've had children. And that genetic mutation potentially has passed through that family, right? Without anybody having any suspicion prior to this patient, right? So that's where this starts to become very important that we understand how we as institutions want to help guide therapy and help families process this information and get the appropriate testing that they need in order to care for their family members. So the other piece that's very important here is that there is not always a good family history for these pathogenic mutations. And so it can be really tricky as you're screening to say, oh, Kelly, do you have any family members who have had cancer? And she might be like, oh, yes, I had an aunt who had breast cancer and I had, a grandparent who died of cancer of some type, right? We hear that a lot when we're sort of doing these family trees. They don't know what type. They're not sure who knows. Everybody who might have known is now deceased, right? There's actually some evidence in the field that says that, oh, actually, we think that BRCA1 or BRCA2 might also, you'll see it there, BRCA2, right, can also give rise to AML. So all those patients that we're testing over in the breast cancer solid tumor world should also be tested for some of these heme malignancy, right, and have surveillance for heme malignancy markers as well, right? So again, just really interesting things within the field in the last, I would say 5 to 10 years. So here we go. This is how we're starting to think about testing patients. A lot of us are very familiar because of the RUNX1 Foundation that that RUNX1 was described as a predisposition for AML in the late 90s. And then that was kind of it for a very long time. Like we knew about RUNX1, we could talk about it, but it is a very small subset of a very small subset of patients who have AML. And now we start to understand that there are actually a lot of predisposing genes, more and more that we're discovering every day as we start to test more patients. And so, about 10 years ago, the World Health Organization actually added myeloid neoplasms with germline predisposition as a component of their 2016 diagnostic classification scheme, right? So that's a really pivotal moment for us as a field to start to think about these germline mutations a little bit more. Sorry about that. So again, recognition of these patients is very, very important. Why is it so important? Not just for that family counseling piece, not just for potential development of the AML later on, but for the talk right before mine, right? Lauren was just sitting here telling us all about how great haplotransplants are. They give us so many more options, right? They give us the ability to cure patients we were never able to cure before. But what if we transplant a patient with a family member who has the same germline mutation that they did? That would be terrible, but in fact has actually been reported in the literature. So there have been case studies where patients have developed de novo AML from a family member that they received a transplant from because they carried the same germline mutation. We just didn't recognize at the time that that was a predisposing condition to AML. So again, really important implications of when we think about this testing and what the ultimate path will be for patients and their treatment and hopefully their cure. Oh, okay, so that was like a lot. It was really heavy, right? Gosh, I know everybody's now sitting here like, do I have a germline mutation? I don't know. I mean, I think the same thing all the time. I'm really curious. And so it's important that we ask ourselves, who should we test for these germline mutations? I mean, gosh, I really want to know. I wish 23andMe would do it, but they don't. If you look at the literature, we used to say, oh, only in very specific cases, really, really minimally do we need to think about this. And now there are all kinds of studies that are saying there is so much we didn't understand that we kind of took for granted that we still don't understand. We should really be thinking about testing everyone. But as you might know, germline testing is kind of expensive. So it can be really, really hard to figure out who can sort of incur this cost, how do we absorb this cost, and still provide the best possible patient care. But there's a lot of programs that are moving towards testing more and more patients. We here at the University of Colorado now test up front on the very first bone marrow biopsy. We send off germline testing for all of our patients with AML who are under the age of 50, who have had a family history of any kind of bleeding disorder, or who have a family history of another type of blood cancer. We developed those guidelines, both with guidance from the NCCN guidelines for germline testing, but also with our own genetic counseling program. And we're developing a more robust genetic counseling support program for both patients and family members who test positive for germline variants. So lots, I think, to be done in the field with this. And I think a lot of opportunities for us to move forward with patients. Yeah, so for our patient case, just in case you were wondering, she did get germline testing. We actually, she was a new patient for us this past spring after our program rolled out. She did not have a germline variant, which was a huge relief for her going into transplant. She ended up getting a sibling transplant, so that was important. But also, she has a young daughter. And that was really weighing heavily on her before she, sort of started undergoing treatment was, gosh, is this something I need to think about? And thank goodness it's not for her, but for other patients it is. But it was really nice to be able to give her that information for peace of mind as she went into transplant. Like, nope, this is absolutely the best care we can say without a doubt that this is the best path forward for you and your treatment. So, all right. Thank you.
Any questions?
Meredith, do you know of any studies assessing like this germline predisposition in relationship to environmental factors that could then elicit like these germline mutations to develop AML? Like, are we that far yet, or is that not going on?
Not that I know of yet, no. What is really tricky is that because it is so newly recognized, there isn't enough information out there yet. We only just started to sort of notice the prevalence of these mutations, like I kind of mentioned, within the past sort of 5 to 7 years. And so it is a very fledgling field, I would say. But I think we're going to be hearing a lot more about it, and there will be more studies like that as we move forward.
Yeah, it's interesting just because like, people also have these germline mutations and then don't develop AML,
Yes.
right? So, so what happens to make that happen would be interesting.
Yeah.
That was a great presentation, Meredith. Thank you. Has there been any, like, I don't know, I feel like I should know this, but for cord blood transplants, is there any like pre-testing for these types of germline mutational issues that are done prior to transfusing patients? Because I know we've had one issue here at the past. So
yeah. We do not typically test cord blood for these germline mutations yet, although I think that it is definitely something to be considered. And now that we understand the prevalence, because again, if you think about sort of historical perspective, like, it's an infant. They haven't been exposed to any of those environmental changes. Like, I'm sure that they don't have any of those somatic mutations that give rise to acute leukemia. Oh, shoot. But now we know that there are these germline mutations that do. And so as this is more adopted and accepted within the field, I imagine there will be more and more testing of those donors, both haplo and cord blood as well. I asked the exact same question when that patient popped up. Lauren's referring to a patient that we had who was transplanted with dual cord And she actually ended up developing, I believe it was a high-grade MDS from her cord blood. So these cases do exist, unfortunately, and again, are just kind of something we want to really be aware of as we move forward with treatment paths for patients.
I have a very important question, Meredith. Do you believe that Cheetos are implicated in germline mutation?
Nothing against Cheetos, guys, nothing. I'm sure that all of that orange dye is really good for you. Yeah, I mean, I was listening to this fascinating story on NPR the other day that you can actually take the Cheeto residue and rub it on mice and see it makes their skin translucent so you can see what's happening in them. I'm just going to throw out there that if Cheeto dust can do that to a mouse, I'm not 100% sure that it won't cause some like genetic changes for you if you eat a lot of those over time, but I'm just throwing that out there, just like food for thought. You can think about it while you eat your Cheetos at lunch.
I do have one kind of more serious question, I guess. So, you think about the patient population that we're dealing with acute myeloid leukemia. These are elderly patients typically, and you talked about all of the different treatments that we have available for us, and thinking about, I think, kind of back to Lauren's talk about allogeneic stem cell transplant being probably the only curative therapy for our patients. Here in Colorado, we transplant patients up to 80 years old, which I think is not common in other places. I think the fit level of our patients is high. But that aside, how do you think about and approach a patient, an elderly patient like this, that maybe comes to us fit enough to go to an allo stem cell transplant? How do you think about them differently in how you're choosing your induction treatment and with that plan of getting them to an allo transplant? Because really induction makes a big difference on your decision of how they, or I think their tolerance of their induction makes a big difference on your decision to get them to a transplant or not.
Yeah, I think it's a great question. And I think what I've seen our docs do quite a bit is, if we can spare somebody the side effects of chemo and potentially all of intensive chemotherapy up front, and get them into a nice remission with Veneza, our nice chemo light, doesn't cause a ton of side effects, really well tolerated, and get them into a CR and then get them onto a transplant real quick. That's lovely, right? We're reducing over time their exposure to other cytotoxic agents, which could actually have them give rise to a different type of cancer later on, but also get them into transplant in sort of as fit of a state as possible. So